Hi, my name is Dr. Jeffrey Cohen. I'm a counselor for the International Psoriasis Council and a dermatologist at the Yale School of Medicine in New Haven, Connecticut, where I serve as the director of the psoriasis treatment program. Today's IPC Take 10 will discuss systemic treatment of psoriasis in high-impact sites. These are my disclosures. First, we need to establish what we're going to talk about. What are high-impact sites? When I refer to high-impact sites, I'm talking about psoriasis that involves the scalp, intertriginous areas called inverse psoriasis, and the nails. As we know, plaque psoriasis is the most common form of psoriasis. However, many patients also have these other subtypes, and it is not uncommon for them to coexist together in the same patient. There are some special treatment considerations when we approach patients with high-impact site involvement of psoriasis. Firstly, these patients are more likely to require systemic treatment. While generally the BSA, or body surface area, is lower than in individuals with plaque psoriasis, they often fail treatments with topicals. And of course, we know that these areas have a high impact on quality of life. The International Psoriasis Council consensus statements suggest that anyone with special site psoriasis is in fact a candidate for systemic therapy. First, we'll turn to scalp psoriasis. This is the most common site of high-impact involvement, and we know that symptoms include itch and pain in our patients. This can be associated with scaling, can lead to embarrassment, and can often impact clothing choices for our patients. We also know that individuals with scalp psoriasis are at a higher risk of psoriatic arthritis. Systemic therapy for scalp psoriasis generally involves the use of biologics. We have data for all classes, however, interleukin-23 and interleukin-17 inhibitors have been shown to be the most effective. Additionally, there is data suggesting that oral apremilast and deucravacitinib are also effective in scalp psoriasis. At a high level, we see that typically systemic agents for scalp psoriasis perform fairly consistently with the way that they perform for plaque psoriasis. Looking at a few trials that were dedicated to low body surface area involvement, such as scalp psoriasis, we'll turn first to the Spectrum study, which looked at guselkumab, an IL-23 inhibitor. We see here that at week 16, guselkumab outperformed placebo by a fair margin and was pretty consistent with what we see for regular plaque psoriasis. I show here photos of a patient who was in this clinical trial, so you can see that this really did clear quite significant scalp psoriasis very nicely for this individual over the course of 16 weeks. Now looking at tildrakizumab, another interleukin-23 inhibitor, we see very similar results, that patients out to 52 weeks had very good response in their scalp psoriasis, fairly consistent with what we see for plaque psoriasis with this agent. Now to turn to some IL-17 inhibitors, first secukinumab. We see here again out to 24 weeks, patients did very well in terms of scalp psoriasis and in fact performed just as well as it does for plaque psoriasis. Now looking at apremilast, which is an oral PDE4 inhibitor. This was a study looking at patients with scalp psoriasis compared to placebo, and we see that about 40%, as compared to only about 10% on placebo, achieved a scalp IGA of 0.1, which is clear or almost clear, and at least 2-point reduction from baseline in this study. Next, we look at deucravacitinib, which is an oral tyrosine kinase 2 inhibitor. Again, here we see that 64% of individuals on deucravacitinib were clear or almost clear on their scalp, as compared to under 20% in the placebo arm. Now we will turn to inverse or intertriginous psoriasis. This involves the skin folds, such as the axillae, the gluteal cleft, the umbilicus, or as you see here, the inguinal folds. The plaques tend to be beefy and pink, and there may be little scale because these tend to be relatively moist areas. Patients with inverse psoriasis often describe pruritus, irritation, or pain, and this can limit physical activity and also intimate activity. As with scalp psoriasis, we see that there is an association between inverse psoriasis and an increased risk of psoriatic arthritis. Looking first again at the SPECTRUM trial for guselkumab, we see that again, patients at week 16 did very well in intertriginous zones. Now looking at the EMBRACE trial for apremilast, again we see that nearly 40% of patients who were on apremilast were able to achieve the primary endpoint. Additionally, we see that there were improvements in the DLQI and discomfort reported by patients using apremilast for intertriginous or inverse psoriasis. Now we will turn to genital psoriasis, which is a special form of psoriasis that involves the external genitalia. In addition to itch and irritation, this of course has a major impact on intimate relations and overall life function. Data suggests that this is underdiagnosed because we as dermatologists do not always check these areas, and patients may be embarrassed to mention that they have psoriasis affecting these sites. Again, genital psoriasis is a risk factor for psoriatic arthritis as compared to plaque psoriasis. The treatment of genital psoriasis is best achieved with biologics, and there are very few studies, unfortunately, that specifically address genital psoriasis. We will look at what exists in just a moment. Oral apremilast has been one of those studied in a phase 3 trial called a discrete trial, and then ixekizumab, and you see images from this study on the top right of the slide, has also been studied. There is data also to suggest that deucravacitinib is effective here. So first we will look at the study of ixekizumab, where we see that as compared to placebo, patients on ixekizumab did significantly better, achieving between 50 and 60% clear or almost clear in terms of response. Additionally, looking at guselkumab in the SPECTRUM trial, we see here that 78% of patients reached the endpoint at week 16 as opposed to only 37% on placebo. And now looking at the discrete trial for apremilast, we see again that about 40% of individuals with apremilast as compared to only about 19.5% on placebo at week 16 were able to achieve this endpoint. Now we will wrap up with a discussion of nail psoriasis. This can occur in isolation or with less than or equal to 5% body surface area, or in the setting of more widespread psoriasis. The clinical manifestations of nail psoriasis depend on which part of the nail unit is involved, and significant disease burden, of course, is associated with nail psoriasis. As we know, this can limit function. Imagine trying to bathe your children, cook your dinner, bathe yourself, type on a computer, use a screwdriver as auto mechanic. The list goes on and on for how nail psoriasis can impact patients' lives. Again, this is a strong risk factor for psoriatic arthritis, and so we really need to be aware of that in this patient population. Systemic therapies come in two forms for nail psoriasis. There is pretty strong data for more traditional therapies like methotrexate and acitretin. We will not discuss those now. And then the immunomodulators, biologics, JAK inhibitors, and the TYK2 inhibitors are very effective for nail psoriasis. First, we're going to look at a lot of data looking at ixekizumab, which has some of the strongest data for use in nail psoriasis. As we can see here in a head-to-head study of etanercept versus ixekizumab outperforms etanercept by a wide margin in the short term for nail psoriasis. Looking out a little longer, week 24, and I will mention that for nail psoriasis, we really want to be looking at a longer term outcome than, say, week 12, because we know that nails take months to grow, and so we're not going to necessarily see our outcome for some time as we follow this out. So looking here at the IXORA studies, head-to-head against guselkumab, ixekizumab outperforms ustekinumab in the IXORA-S study, and then in the head-to-head study of adalimumab, ixekizumab also outperforms. Now looking at 52 weeks, and this is really where the best data is for nails because of the amount of time it takes nails to grow. You can see here ixekizumab outperforms ustekinumab and adalimumab at week 52, and so that shows us that ixekizumab is really a very strong drug for nail psoriasis. Secukinumab, another interleukin-17 inhibitor, also did very well in the long term, out to 2.5 years, clearing nail psoriasis in a large proportion of patients. Interestingly, in this Transfigure study, they also looked at life function. And you can see that functioning as compared to placebo or even lower dose secukinumab was maximized by the highest dose, 300 milligrams dose of secukinumab, and you can see that here. Looking at bimekizumab, our IL-17A/F inhibitor, consistent with what we saw for the other IL-17 inhibitors, there's really good nail data that seems to last long-term, out to a year. Again, looking at risankizumab now, this is an interleukin-23 inhibitor. We see fairly comparable, really nice nail data that lasts out to several months into a year, and so we feel pretty confident using IL-23 inhibitors for nail disease as well. This is looking at the limitless study, longer term, as I mentioned, for risankizumab out to 52 weeks and beyond. And then looking at deucravacitinib, again, fairly consistent to what we've seen for other body sites. This does a very nice job of managing nail psoriasis as well, not to the level of the biologics, but it does do a nice job. This is an interesting study, the UPJOINT study, which looked at patients with psoriatic arthritis with nail disease. And we see here that in a large proportion of those patients, nail disease did get better, showing that upadacitinib is effective for nail psoriasis as well. In summary, high-impact site involvement of psoriasis requires special consideration. It's often more recalcitrant, there's a high burden of disease, and there are several important forms for us to think about. Systemic therapy is generally required, and while there are many systemic therapies that have been shown to be helpful, there are certain considerations that may push us to one or another in specific instances. And we didn't get to talk about this too much, but combination therapy may also be needed for high-impact site psoriasis. This is a summary table that I provided for your reference, which I hope will be helpful. And I appreciate your time and attention. I hope you've enjoyed this IPC Take 10, and I'm happy to take questions via email anytime. Thank you for your attention, and have a great day. Bye-bye.